Hello, everyone. Welcome. Thank you so much for joining us for today's Focus Bites webinar. My name is Daria, and I will be your webinar host today. The webinar is now beginning. All lines have been muted. Please use the Q&A box for any questions or the chat box for comments you have throughout the webinar. Today's topic is POCUS benefits and implementation strategies, and our speaker is Dr. Tatiana Havryliuk. Dr. Havryliuk is an emergency physician, formerly ultrasound director at the Brooklyn Hospital, and the founder of Hello Sona. Welcome, Dr. Havryliuk. We're so excited to have you here with us today. Thank you so much for agreeing to present.
Thank you, Daria, and thank you, POCUS Certification Academy, for hosting this webinar. And I'm super thrilled to be here today talking to all of you about POCUS, its benefits, implementation strategies, and ROI. Let me just start my slide deck over here. And I would love to know where people are from and what specialty they're in, and if they're currently using POCUS in their clinical practice. I have a feeling we have quite a diverse crowd here today. So please go ahead and share in the chat. I am joining all of you from New York City. A little bit about myself. I know you, Daria just introduced me, but some things you might not know about me. Well, first of all, I'm an emergency physician. I completed my residency and fellowship training in Mount Sinai in New York. But one fact you might not know about me is that I actually did a wilderness medicine fellowship first. And that's when I really fell in love and saw the value of POCUS, because I was practicing in really remote and austere places. And that was my only diagnostic tool. And that's how I hopped on the wagon of POCUS. I also have clinical experience in urgent care settings and global health projects. I ran a very robust program at the Brooklyn Hospital for their emergency residency for over 3 years. And I also speak and do workshops at various national conferences. And as Daria said, in the last 2 years, I started Hello Sona really with the mission of bringing the benefits of POCUS to more clinical practices and hospitals by providing them support with the implementation and also with provider credentialing. This is a picture from Everest Base Camp at 17,000 feet. And this is actually Everest CR, a tent where I worked for 2 months during the climbing season. And I actually slept in one of those little yellow tents for 2 months. It was quite a lot of fun. And hey, we had POCUS. It was our only diagnostic tool, and it really saved us so many times and our patients. This is a picture of me performing ultrasound on a patient that came with flank pain, and he ended up having infected urine on the urine dip. And on my ultrasound, I found moderate hydronephrosis. So, of course, my concern for an infected, obstructing renal stone was quite high. I treated him with IV ceftriaxone, and I evacuated him via helicopter to Kathmandu for a potential stent. But ultrasound was so important for our clinical practice in general. We were diagnosing patients with undifferentiated dyspnea, looking for B lines for high altitude pulmonary edema. We were also had quite a bit of abdominal pain patients with HACE, high altitude cerebral edema, looking at optic nerve sheath diameter. And also, we actually had a pregnant patient in first trimester pregnancy where I had to rule in an IUP and make sure it's not an ectopic. And on the right over here, you see a picture of frozen gel. That was pretty much what was happening every single morning. And this serves you as a reminder, if you are going to take your devices out in the cold, be mindful about your gel and also the battery life of your device, because we actually had to sleep with our device in our sleeping bags to keep the battery from dying every single morning. And this is what I'd like to cover with you today. First of all, I want to make sure we're on the same page of what POCUS is and what it's not. Why do we care about it now? What are the benefits for the patients, clinicians, and also medical practices and hospitals? What is some of the evidence behind the benefits of POCUS? And then we'll hit on the implementation strategies, the key components, what are some of the credentialing guidelines, and what kind of documentation you need for billing purposes. And in the end, we'll dive into the ROI. All right, so what is POCUS? It's a clinician-performed ultrasound that answers specific questions at bedside in real time. It is meant to be quick, 1 to 5 minute exam, and it's very distinct from a comprehensive exam that an ultrasound tech does, and it might take 20 minutes or so, and then the radiologist interprets in a couple of hours to maybe even a couple of days sometimes, right? It's very different. It's quick, it's focused, and it's been proven over and over again to be very teachable, and it's also billable. The POCUS is built with limited ultrasound CPT codes, and if you are doing POCUS right now and you are not billing for it, you're literally leaving revenue on the table. And the cool thing is that in the last couple of years, we've got so many different POCUS devices coming out, from handhelds that probably most of you are thinking of when you think POCUS, to more classic card-based systems, and also laptop devices. So there's so many choices out there for you all who are who are shopping around. All right, let me check the chat real quick. Let me see where people are from. We've got Dallas, Texas. Stacy, thank you. Hello. Oregon. Toledo. Wow, okay. Wow, and then we got Nigeria. Welcome. Knoxville, Tennessee. Houston, Texas. Awesome, guys. Thank you for sharing. Lancaster, Ohio. Well, I hope Portugal. Wow, amazing. Well, I hope everyone is staying safe and warm. We have a crazy cold spell and a winter storm in the United States right now. All right, moving on. So why do we care about POCUS right now? Well, number one, now POCUS is a lot more affordable. Butterfly was one of the first more affordable devices, portable handheld devices. Now you can get it for what, $2,700 a whole device versus $40,000 that we were paying for a card-based system in the past, and that was our only option in the past. We now have over 2 decades of evidence showing how POCUS improves patient care. And it comes from emergency medicine literature, ICU, hospital medicine, and now more and more from the primary care. And for those of you in the United States, Medicare is trying to really move away from fee-for-service world to a value-based care model by 2030. And that means lower cost of care, but more quality care and patient-centric. And luckily, POCUS fits all of those criteria. It's now also backed by multiple organizations, from ASAP to ACP to AFP. Now ACGME put out ACGME as a governing body for residency programs. And it put out a statement last year urging all of family medicine residents to get training in POCUS during residency. And similar situation is happening in internal medicine world. And finally, if you are practicing in a private sector and in a fee-for-service type of model, there's been decreased patient volumes, and POCUS can be one of the ways to increase your patient volumes by offering a new service and differentiating yourself from other practices. And on top of that, you get an additional income stream by keeping some of the imaging in-house and being able to bill for it. So lots of reasons why implementing POCUS right now is top priority for a lot of places. All right, I'm going to start with a case, and it is, of course, Friday night, your last patient of the day. It's 4:45 p.m. You're in your primary care office, and you've got a 56-year-old man, we'll call him Mr. Google, who comes in with left calf pain for 1 day. He's otherwise healthy and active gentleman, but he had a flight from California to New York. That's a 5-hour flight 2 days ago. And he comes in and he said, I Googled this, and doc, do I have a clot? Right? He's already worried about it. On exam, his vitals are normal. His lung exam is pretty much unremarkable, other than some calf tenderness, but there's no swelling, no skin changes, no neurovascular findings. So, of course, you're hoping it's a strain, but you're wondering, is this a DVT? And please put yes in the chat if you've encountered a similar case in the past. I'm curious. All right, well, I'm going to keep going. So if you don't have point of care ultrasound, there there's a lot of variability of how different clinicians are going to handle this, but there's definitely a ton of uncertainty. So some people might send this patient to the emergency room that evening, basically confining this patient to sitting in the waiting room for probably 4 hours to get this Doppler study, and there might be not even an ultrasound tech to perform one on a Friday evening, not in the hospitals I worked at in New York City. Alternatively, you might choose to treat this patient with anticoagulants that's potentially exposing him to risks of bleeding while waiting for definitive testing. Or you might choose to get a D-dimer on this patient and hope for the best that it's going to be negative, but that might also not come back in a reasonable time, given that it's going to be the weekend. In the end, we don't really have the answer. We are not giving the best treatment for the patient. And there's probably costing your patient a lot of nerves and probably some money. And then say you do have POCUS and you do 1 to 2 minute compression exam of the lower extremity vasculature, and you confirm that there's no proximal leg clot. Right, so now you can reassure this patient there's nothing dangerous going on. This is most likely a strain. However, there's a small chance this is a calf DVT, so he might need a repeat study in 5 days. But you might choose to get a D-dimer, and if that's negative, then you fully rule this out. So you see how much different that is in terms of the patient experience and even the clinician experience having POCUS versus not. Right, I'm going to check the chat one more time over here. Oh, I got 2 yeses. All right. And then we got people joining from Germany, Argentina, India. Oh my God, this is so awesome. Thank you guys all for being here today. And this is just a slide showing to you how simple point of care ultrasound is. We are literally looking for a very focused thing. Is there a compressibility or not of the vessel? On the left side, you can see a fully compressible vessels. So you see the greater saphenous vein here all the way to the left, draining into the common femoral vein, and they are fully compressible. And the femoral arteries to the right are not compressible, which is normal. So that leg doesn't have a DVT. Versus on the right side of the screen, there's 2 non-compressible vessels, and the bigger one is the common femoral vein, which has a clot, and that's why you can't compress. So you might not be able to see the clot very well, but you know that it's not a compressible vessel, thus this patient has a clot. All right, so what are the benefits of ultrasound? I'm going to go over some of the obvious benefits and then move over to some of the less obvious benefits of ultrasound. All right, so number 1, as we just showed, it improves diagnostic certainty. Is there a DVT or not? Is there an abscess? Is there a pneumonia? It avoids radiation, and that is super important for pediatric patients and younger adults. It also saves costs for your patients who might not need to go to the emergency department or get more expensive imaging, and also saves costs, overall healthcare costs. It is efficient. It's super efficient for a patient because they don't need to take time off from work to go to another appointment right now. You can give them the answers right now and get them on an appropriate treatment. But I also will argue that it's more efficient for the clinician themselves, because now you and your team don't need to arrange a follow-up study potentially, and also making sure your patient gets that follow-up study, and then following up the results, and then contacting your patient, letting them know what the results were, right? So you can do all of that in 5 minutes at the bedside now. And of course, POCUS also improves safety of various procedures from central lines, paracentesis, thoracentesis, and it also decreases the number of attempts of those procedures. So in terms of your patient experience, it's almost also so much better. All right, and now we're going to hit on last obvious benefits of POCUS. Improves patient compliance with imaging. Okay, that same DVT patient that you're seeing on a Friday night and you're telling them like, hey, go to the ER, I'm concerned you might have a blood clot. How many of the patients will actually go to the ER to get that further imaging, right? So type yes if that has happened to you, where you tell the patients to do something in terms of imaging, and then 6 months later, you check their chart and nothing has been done. They did not follow up. Are there some yeses? All right, I'm waiting. All right, it also enhances patient and provider experience, and I'll touch on that a little bit later. It's a marketable skill and a transferable skill for the providers. It also indirectly decreases litigation because now you are making decisions with more data. So you're managing your patients with less mistakes, and you're also performing procedures in a safer manner. And finally, it decreases ED referrals and ICU admissions, right? So the ED referrals for the rule out DVT, your chronic CHF patients, and ICU admissions for various reasons, either avoiding central line placements by actually putting peripheral IVs with ultrasound guidance, or also managing your patients who are extremely sick with more data by doing POCUS to see their fluid status, to see what's going on with their heart and lungs. All right, I have 3 slides on the evidence, and I really picked the highlights because there's so much out there. So this is the evidence more on the diagnostic studies. One study of the emergency physicians found that they were wrong 56% of the time in terms of if a soft tissue infection without an obvious abscess needed drainage or not. So it's a flip of a coin. POCUS makes us pretty much 100% accurate. So imagine you might be saving your patient an unnecessarily painful procedure by doing POCUS first. And you might be saving time for yourself, right, by avoiding unnecessary procedure. This is a study on elderly patients in inpatients, and it found that POCUS had 90% sensitivity for pneumonia as compared to chest x-ray, which was at 47% in that particular study. And really, the lung ultrasound literature shows that it's pretty much consistently superior than chest x-ray in diagnosing pneumonias, pulmonary edema, and also pneumothorax. All right, this is a study from the ER, and that was really a landmark study showing that on patients presenting with a possible renal colic, they were able to avoid CTs on 60% of the patients by applying POCUS first approach. And this was 2014 or 15 study. So it's quite an old study. This evidence had been out there. They had a large amount of patients. They also showed that it increased throughput and decreased costs and also saved radiation exposure. So this is a really key study. And if you're not using POCUS for your rule out renal colic patients, this is really time to use POCUS. It really has a lot of evidence behind it. All right, and another study showing that arthrocentesis was avoided in 37% of the patients because when you did the ultrasound, you noticed that there was no fluid to be aspirated. This is another example of how POCUS can be very simple, especially if you're looking for a specific question. Is there hydronephrosis or not? On the left is the normal kidney. It has hyperechoic, a white center, which is normal. On the right side, you see a kidney with hydronephrosis, and and you know that because there is black or anechoic center that's indicating fluid, and there's dilatation of the pelvis that extends into the calyces. So there is actually a moderate hydronephrosis in this case. All right, and this is a little bit more of a procedural evidence on POCUS. This is a European study out of Italy showing that there was an absolute 11% absolute pneumothorax reduction during thoracentesis. So normally without ultrasound, the pneumothorax, iatrogenic pneumothorax rates are anywhere from 8 to 12%, and with POCUS, you're reducing them to about 1%. I mean, that is remarkable in terms of patient care, the costs, the length of stay in the hospital. Another study showed that POCUS changed needle insertion site during paracentesis in 69% of the cases. And another study also showed that paracentesis was avoided in 20% of the patients because when you did POCUS, there was no safe pocket to be able to do the tap, right? So you might have been doing a dangerous procedure for the patient if you didn't have POCUS. And of course, complications in central lines, right? 71% reduction in IJ central line placement with POCUS. All right, and here's my last slide on evidence. There's two European studies, one showing really patient experience when they were getting POCUS in a primary care practice. So about 8 to 9% of the patients got POCUS during their primary care visits, and they studied over 500 patients. What they found is that patients felt more thoroughly examined 92% of the time, and also 95% reported that they felt POCUS improved level of service. Some of the patients, 65% of them, said that they also trusted their physicians more when POCUS was performed. So if you're trying to get your patient rankings up, POCUS is definitely helpful in that. Okay, and this is another study from primary care in Europe that showed that POCUS changed management in 71% of the cases, and that included everything in terms of final diagnosis changes, referral changes, and the actual treatment plan change. All right, well, I hope you find this evidence compelling. I've got a second case for you, and you've got a 33-year-old female with right groin pain and swelling for 3 days. She has no fevers. You examine her, and there's induration, erythema, and warmth in the area, but not quite fluctuance. So, of course, you're wondering, is there an abscess that needs drainage versus is this a reactive lymphadenopathy with cellulitis versus something more rare, like potentially a hernia or vascular issue? So with no POCUS, there's really not an ideal solution, right? So you might start this patient on antibiotics and warm compresses and have them come back in a couple of days. You might do needle aspiration and hope you are not biopsying a lymph node and convert it into IND if you get pus, or you might go and do an IND and hope for the best. And if you don't get pus, you just put your patient through a necessary procedure. Versus you do POCUS. And please write in the chat if you've had these encounters before where you had a patient with a skin infection where you were not sure whether there was an abscess or not. And kind of what was your management strategy at that point? And so you do POCUS, and that's literally like a 30-second exam in this case. You just put the probe on the area of interest and you find this, right? There's a clear fluid collection, which appears anechoic with debris inside of it. And you can even put color flow to make sure this is not vascular. You can look at the depth of how deep you need to cut and to get the drainage. You can also visualize the size of it and any kind of loculations. With the color flow, you also want to make sure that there are no vessels superficial to the structure to make sure you are not going to cause any bleeding when you do the IND. But all of a sudden, you get such a better idea what's going on with the patient, what is the treatment that's indicated, right? So IND and antibiotics, and this patient might not even need to return to your office anymore. And another cool thing about POCUS is that you can actually repeat ultrasound after you did the IND to perform that you didn't leave any large pockets of fluids behind. All right, so what's the impact on the patient? In the end, patients get better care, they save time, they understand their diagnosis better because you can actually show them what's going on inside of them and educate them. and they get to pay less, right? So overall, the POCUS enhances their overall patient experience. And what about the clinicians? Well, as we said, they get to acquire new skills, which is a marketable skill. They get to keep up with the new standards in medicine, and POCUS is here to stay. And they also get to avoid the frustrations and really the frustrations of that uncertainty of making medical decisions without enough information. And also the frustrations of needing to make follow-up appointments and then following up with the patient and making sure that they got their study. And what about primary care practice? What are the benefits for them when to integrate POCUS? So they get to decrease their ED referrals, like this patient with DVT, also CHF patients. They get to expand their services in the hopes of attracting new patients and differentiating themselves from other practices. They get to increase their patient compliance with imaging. They get more satisfied patients and providers, and who doesn't like that? And they get to see increased revenue by keeping POCUS, by keeping some of the imaging in-house and being able to bill for it. So the bottom line is POCUS improves care while bringing in additional revenue for primary care practice. All right, and let's look at the hospital. Well, they get to decrease ICU admissions, and for various reasons, as I mentioned previously. They get to reduce their length of stay in the ER, also in the hospital, right? So they can actually have a larger turnover of patients and see more patients, just generating more revenue potentially. They get to decrease their iatrogenic complications. They save costs by ordering less expensive tests, by reducing their LOS, by having less litigations, by practicing safer medicine. They get more satisfied patients, so they get their rankings up, and they get to meet quality measures, and quality measures are oftentimes tied to reimbursements. All right, we're going to switch gears over here. Actually, there is a question, so maybe I'll just take a look at the question. How do we incorporate organized formal POCUS training? Many dangers with POCUS use without proper training across most users. Totally agree, and we will address this in just a few slides right here. I think the second slide. Great question. All right, so what do you need for a successful implementation? And I really want to give you kind of the 10 key components that you need to have in place to run a robust program. Number one, you've got to have a POCUS champion, someone who is going to be on the ground and someone who's going to be the point person if the machine goes offline or it's not working at all, or there's a new provider that's coming in and we need to verify their credentials to make sure that they are competent in ultrasound. You want to get IT and biomed involved as early as possible as you're planning this implementation. And that's because they get a lot of say in the hospital, right? So for IT, they might have a lot of say on what kind of software you're going to bring into the system in terms of security standpoint and the personnel that they have available to manage that software. Biomed might have their own preferences in terms of the device companies to work with. And of course, other key stakeholders would be your radiology department, other heads of of other departments, right? Someone that might be potentially already doing POCUS, you want them to bring them in early on and get their advice and input and buy-in. All right, of course you need the devices, and there are so many devices out there to choose from. So you really need to think about the portability, right? So do you want the pocket size, the laptop system, or a card-based system? And then what features are important to you? So what kind of, are you going to be doing a lot of echoes? Do you need an advanced cardiac functionality? Do you need color Doppler? Are you doing a lot of ultrasound guided procedures that need additional packages? And if you do have a lot of novice users, you might want to have a lot of AI features incorporated. And then, of course, what's your budget for the device? So consider all those things before you commit, and definitely consider biomat preference before you buy the device. And then you need to have some kind of storage and QA solution. And storage is super important because you cannot bill for these ultrasounds in the United States unless they are stored indefinitely in a secure manner. Right. So there you might be able to store if you're in a hospital system on your PACS system and share PACS with radiology. That's a discussion to have with the radiology department and IT, or you might need to invest in a cloud solution or some kind of middleware. Number 5, you need to have protocols in place to run a compliant and safe and high quality program. So what are your credentialing protocols? What are your machine maintenance protocols? What are your infection control protocols? What is a protocol on providers bringing their own ultrasound equipment, so pocket held device, and do ultrasounds on the patients within your hospital or within your medical practice? Are you going to allow that? Is there a process they need to go through? So having those protocols in place is very important. Documentation, especially if you're billing for this, you got to have it documented. So having templated procedure notes is the best way to go in this case. And I'll go over the documentation a little bit in a couple of slides. You got to make sure your providers undergo the credentialing process. So whatever you agreed on in your protocols, you make sure that your providers meet this. You want to have a quality assurance program in place. Usually it's recommended that after your providers are credentialed, you still want to review at least 5% to 10% of their exams for quality to make sure that it stays on par with the standards. All right, and if you are in a hospital system, before your providers can perform these diagnostic exams with POCUS, but before they can start billing and making medical decisions, they need to make sure they got their privileges approved by the board, right? So make sure you have those steps in place before you're performing diagnostic tests. And number 10, after you have all of this in place, you can finally start billing. And for billing, documentation is really important, and also making sure that the properly trained providers are doing POCUS. All the components in orange, red are actually part of the workflow, right? So when you're building your program, you want to make sure your workflow is as seamless as possible so that provider doesn't have to do a lot of steps to do POCUS, right? So having a single sign-on for the device and the QA solution and your EMR might be a good idea, or making sure that there is a documentation is integrated from the QA solution, whatever QA solution you're using, directly into the EMR. But the less buttons you click, the better. And the less steps you have, the better. And also, one thing I forgot to mention in terms of billing, when you are going to implement billing, it's very important to educate your providers and your coding and billing team, right? So let the providers know what is necessary in terms of documentation, and let your coders know the new CPT codes you're using so they can be actually watching out for those. All right, I see there's another question over there. Oh, there was a question about case 1, would you scan the whole leg or only the pop and calf for DVT? So actually that case, the DVT case, I would actually scan the proximal vasculature, including up down to popliteal. And if I can see, I would continue more distally, but I wouldn't necessarily do the calf ultrasound because sometimes it can be very challenging. What we care in that scenario is really proximal DVT, right? Because if it's a proximal DVT, it might embolize and cause a PE and have devastating outcomes. So as long as you did a proximal leg scan, then you can reassure the patient, hey, you don't have anything dangerous going on. There might be a calf DVT. We tried to look for it, we didn't find it, but we'll send a D-dimer to make sure that we can roll you out, or we can get a repeat imaging if you have persistent pain in the next 3 to 5 days. I hope that answers your question. All right. My next slide is really on credentialing guidelines, and there's quite a few out there, but most of them have very similar components and are based on the ASAP, American College of Emergency Physicians guidelines. You want your providers to have some kind of passive learning experience. So there's a ton of online content, right? Lots of videos and quizzes, so blogs, etc. So those are a really good place to start and also continue learning, using for continued learning. There's also great books out there, ebooks with videos in them that are really, really good and a lot of times free resource. Ideally, you want your providers to have a hands-on workshop that they undergo. So 1 or 2 day course. And that's really to make sure that their hand-eye coordination is working, that they are holding their hand correctly, that they are getting the appropriate views and getting live feedback from the instructor. Although some of it you can do remotely, I think the hands-on workshop is really irreplaceable. Then you want your providers to develop the practical skill. So give them some time to perform educational scans only, right? And it is recommended in general to get 25 to 50 scans of each exam type. And those should be reviewed for quality before the provider can be deemed competent, right? So if you're going to be getting credentialed in echo and lung and musculoskeletal, you should be getting 25 of those, at least a minimum of 25 of each of those reviewed. Assessments, also important. There is a ton of places where you can get online quizzes, various certifications, including POCUS Certification Academy. They will put you through the test to confirm your knowledge base before giving you that certification. And then you could also be pulling reports on quality of images and accuracy of interpretation if you are using a QA and archiving system. And then don't forget maintenance of credentialing. So once you become credentialed, it's still important to keep up with your skills. So it is recommended to get 3 to 5 hours of CME every 2 years, and also perform at least 10 scans of each exam type per year. In addition, as I mentioned, get 5 to 10% of your exams reviewed for quality. And these maintenance of credentialing are really based on the ASAP guidelines. All right, and what are the billing, storage, and documentation requirements? Well, number one is, I think you should put in an order. Although it's not required, putting an order in really clues in your coders to look for the procedure note. So it's a good habit to put an order in. You need to make sure you have indefinite HIPAA compliant secure archiving, right? So whether it's PACS, whether it's cloud, but you need to have that before you can actually bill. And then you've got to have your procedure note, and those you can make templates. Whereas your procedure note should have the indication of why you're performing the exam, the views you obtained, the findings, and then your final impression. And don't forget to timestamp it. And the last part that's really important is the medical necessity, or you got to document it in your MDM section, because if you're looking to get reimbursement for this, this is basically a key component in medical necessity. And it's also what makes sense in your chart, right? Putting in that medical necessity. All right, to have a robust POCUS program, I believe it should have 4 components. It should be as seamless as possible in terms of the workflow. And the less steps, the better. The more automated it is, the better. It needs to be of high quality, meaning your providers have undergone appropriate training and credentialing process, and you have a quality assurance system in place. And number 3, it needs to be compliant with billing regulation, with your state, with your organizational protocols, etc. And lastly, I firmly believe that a robust POCUS program should also be profitable. You are performing an exam that is a billable procedure, and you invested into the equipment and the training to to have this, and you're improving patient care. So it's only right to be able to bill for it, to be able to support this program, right? So if you're billing for it, you'll be able to upgrade your machines, train your new oncoming staff, and also provide CME for your staff. All right, so I'm going to move into the ROI, return on investment with POCUS. And I know we have a lot of international participants here. I'm sorry, I do not know much about ROI other than what we have in the United States. So my apologies. I hope some of this will be applicable to you. So when I think of ROI, I think kind of two different ways ultrasound can bring in revenue. One is more direct way and one indirect way. So the direct way would be the direct billing. You did a procedure and you documented it. Your coders and billers build for the CPT code attached to that procedure. That's easy. And that works really well in a fee for service type of environment. And then you've got also an ability of POCUS. You can use it instead of direct billing. You can use it to increase your E&M code complexity, so evaluation and management code complexity. So that might be a good way to go if, for example, the CPT code for the procedure is not part of your contract with the private payers, right? So you're not able to bill for the specific CPT code, but you can still use it to increase the E&M complexity. So these are more direct ways. And then the more indirect ways is POCUS does help you get your quality measures, right? So in terms of safety of procedures, you're avoiding iatrogenic complications. So that's in the United States, at least, quality a lot of times is tied to reimbursement. So the higher the quality you're provided, for example, if you're participating in different MIPS improvements from CMS, you might be getting paid up to 9% more than 9% more. And well, another thing in quality measures is patient experience, right? So tying this to improved patient experience will also get your ratings up and hopefully more reimbursement. And then improved efficiency is another factor to consider. So especially in the emergency departments and in the hospital, if you have higher turnover, you're able to see more patients, and thus you are able to generate more revenue. All right, and of course, if you are in your value-based type of model, cost savings becomes really important. POCUS is a lot cheaper, and I'll show that to you in the slides, than a lot of other imaging modalities. And remember, you also might be avoiding ICU admissions, ED visits, readmissions, iatrogenic complications, litigation, so many different other things. As a cost savings is important as an indirect way of bringing revenue. All right, this is going to be a little bit of a busy slide, but this is going to show you the most current reimbursement rates for POCUS performed in non-facility setting. So non-facility meaning an urgent care or a private office, something with place of service 11 for those of you in the United States. 11 or 20 would qualify. And here I'm going to be reporting the global payments, meaning that the professional component and the technical components are combined. All right, so these are the most commonly performed POCUS exams, and really the reimbursement ranges from $56 for lung ultrasound to $180 for FAST. And these numbers will be obviously different if your patient is part of Medicaid or has a private payer. So private payers in general pay 120 to 160% of whatever Medicare pays, and Medicaid pays 70% of whatever Medicare pays. All right, and then for procedural guidance, so here I also indicated the additional payment you would get by doing ultrasound. So anywhere from $28 to $57, that's on top of whatever you're billing for that procedure, right? So if you're billing for arthrocentesis $90, then on top of it, you would be getting the 28. All right, and here I kind of put together some numbers to make it a little bit more tangible. So we have a primary care practice that's performing this many exams per month, right? So 12 long exams, maybe for their CHF patients, dyspneic patients, cough patients, patients with cough. And then they're performing this many soft tissue MSK, so rule out abscess, maybe hematomas, joint effusions, um, with tendinopathies, tendon tears, right? So I put 18 over there, and obviously you can adjust those numbers. And then this many fast DVTs, et cetera. So if this primary practice is performing this many exams per month, then they are able to generate additional $70,000 annually from their POCUS program. And here, obviously, these are estimates based on reasonable use of POCUS, and we are not including any of the procedural ultrasounds here or more advanced ultrasounds like ocular or pregnancy ultrasounds. All right, and if you would like to get a more precise number, an estimate still for your particular practice, if you're in a primary care or urgent care world, you can scan this QR code and it will take you to a free POCUS ROI calculator with the updated numbers, and it can basically give you a number for your monthly expected revenue and annual expected annual revenue. This is a slide on, once again, direct billing, but this is for facility professional payments. So this would apply to an emergency department, maybe a hospital group that's not employed by the hospital themselves, um, or an outpatient, like attached to hospital type of clinic, right? So service codes 19 and 21 would be applicable for this. And we are only including professional payments in here because the hospital gets to pay for gets to bill for the technical component. All right, so the reimbursements are going to be less because this is only professional component. So the range is anywhere from $20 to $50. And for the procedural component, in addition, you're able to charge $13 to $29 in addition on top of whatever the procedure fee is. All right, so I included this slide because I think it's important. So many people are doing ultrasound guided IVs right now, and they're not billing for them, and it's literally revenue left on the table. So venipuncture by physician with ultrasound guidance, the facility fee is $22, non-facility fee is $55. And it's not just IVs, it's any kind of venipuncture for a blood draw that counts. Right? So if you were doing 1 a day or 7 a week, you would be generating additional $8,000 annually for a facility-based practice and $20,000 for non-facility practice. But the caveat here is you've got to store your images, right? So you've got to save a clip of a compressible vessel and also showing the catheter in the lumen of the vessel. Right, I think there's another question over here. Let me look. Okay. There's another question about giving an example of how POCUS can be used to increase E&M complexity. So instead of documenting it as a procedure note, you can document it in your medical decision making, saying, I prefer this ultrasound because I was looking for this pathology, and that elevates your complexity of the case. And this is what I ruled out by doing this. This is what I was concerned about, and this is what I ruled out. And I reviewed all of the imaging myself. I hope that answers this question. If not, I would be able to talk to you offline as well regarding that. All right, so what are some reimbursement challenges? Number one, lack of documentations. If it's not documented, it's not billable, period. So there are no procedure notes, or there are no orders. The coders just are not able to bill for it. So you got to educate your providers and putting those procedure notes and medical necessity into the MDM. Okay, why would we get denials? Well, a couple of reasons. One is inappropriate or inadequate documentation. So say someone put in the procedure note, but there was no medical necessity, then that claim will probably get denied. Another reason would be duplicate studies, so repeat studies done by the same provider, or potentially doing the patient already got the comprehensive ultrasound and radiology department, and then you did the limited ultrasound afterwards. So that would not be reimbursable. And another reason for denials is if the CPT code you're using is not actually part of your contract with a private payer, for example. Yeah, and that brings us to how to negotiate the private payer contracts. So what are your options? If you're in, number one, verify whether the CPT codes that come with limited ultrasound are part of the contracts right now. If they are not, you have a couple of options. You can do a carve out with your private payer and put those CPT codes in, or you can wait until your contract expires, and during the renegotiation time, you can incorporate the CPT codes. All right, guys. It seems like there's another question over there. Can you bill for ABG puncture ultrasound? I haven't specifically looked this up, but I don't see why not. It's POCUS guided procedure. So if you're using POCUS and you are saving the clip, I am 95% certain it's true, but I would need to specifically look that up. All right, I didn't want to leave you guys with an ice cream on the floor image. So instead, I'm going to leave you with this image. And that's a happy puppy hopping through the snow. And I hope you found some valuable information in my lecture. I would like to encourage you to email me if you have any further questions. Connect with me on LinkedIn. It's Tatiana Havryliuk, MD. There are two QR codes on the screen. On the left side, it's the QR code for the ROI calculator, which is free. On the right side of the screen is actually a Calendly link to my calendar for a 15-minute call if you want to discuss something quick. So thank you so much for your attention, and let's see whether there is more questions.
There are definitely some questions that came in. Would you like to maybe go over our poll questions first, or do you want to answer the Q&A first?
Oh, the poll questions. What are the poll questions?
The quiz questions.
Oh, yes. We've got the quiz questions. That's right. All right, I'm going to stop sharing so we can. I forgot about those. Yes, let's do the quiz.
All right. Okay, launching the first quiz question. Lung ultrasound is significantly better than chest X-ray at diagnosing pneumonia, right? You should all see it on your screens, and feel free to answer this quiz. I'll give about a minute for everyone to answer. So we have about 33% of people who are watching us answered. So I'll give another 15 seconds. Okay. Okay, here are the results. Would you like to comment on the correct answer, Dr. Havryliuk? Oh, you're muted.
Great job. Most of you got the correct answer. It's true that I mean the specific study that I cited showed a huge discrepancy, but even other studies do show that ultrasound is a lot more sensitive for pneumonia and a lot of other pathologies in the lung than X-ray.
Perfect. All right, moving on. Question number 2. Which of these is an important component of successful POCUS program implementation? Maybe. Not a tricky one, if you had paid attention. Right. I see about 50% people who are here answered, so give another 10 seconds. Right, and here are the results.
All right. Well, all of the above is the correct answer. So good job, guys. In addition to 7 other components that are key for successful implementation.
The last question. What is the approximate number of educational scans of each diagnostic POCUS exam type is recommended for credentialing purposes? Maybe a tricky one. Okay, I'll give you another 10 seconds. Okay, here are the results.
All right, well, that was maybe a little bit of a tricky one, but most of you got it right. So 25 to 50 is kind of more or less the standard. Once you get into more of a advanced echo or maybe, radiology type of path, then of course more is going to be beneficial and there's going to be more of a requirement.
Okay.
Good job, everyone.
Yes, thank you so much. I do have one last question. And we can continue our discussion, but this will help us to really understand what other topics of the webinars we should be bringing. And did you learn anything today? So give us all the feedback that you can. But we can move to the Q&A portion and see if you have any questions. You can submit them to the Q&A box as well. But I saw a couple of them came in. Did we answer them all? Maybe. How do we incorporate organized formal POCUS training?
Yeah, I think we did. I think there was a question in the chat about credential versus POCUS certificate or training and residency program. I mean, that's a really good question. Credentialing is something that happens internally, so within the institution, and they create their own protocols, and usually they are following some kind of guidelines from an organization, right? So I, as an external company, I can't go in and just credential necessarily someone. I can support them in the credentialing process by, for example, doing their clip review and helping with the implementation, but I can't give them the credentials. Certification is different. Certification is something that can be given by an external company or external organization. And you do want to be careful when you're getting certifications, because they are not all the same, and some of them are a lot more rigorous than others, right? So you want to make sure you're getting certifications from a recognized organization that has very robust kind of criteria. Yeah, and then or training and residency program. Well, I think training and residency program is your best bet, right? Because you'll get the longest exposure to POCUS and educational materials. But even after you complete your residency program, when you go and you apply for a job somewhere else, you'll need to get through their credentialing process. And usually for that, if you already had POCUS in your residency, they might want to watch you scan, see your numbers, right? So you'll need to turn in your residency numbers. So you performed 150 exams, and then there's a breakdown of how many of each, and your ultrasound director sends that to your job. And then the job might want to actually make sure that you can scan well. So they might want to see you scan a few times before they tell you, hey, you're credentialed. You can do diagnostic tests in our hospital, in our institution.
Thank you so much, Dr. Havryliuk, for covering, all of the questions and giving this excellent presentations. Thank you for taking the time to present, and thank you everyone for taking their time to attend this webinar. We hope you enjoyed everything. If you have any questions, just let us know. We'll send you some more information in our follow-up emails, but this was also recorded, so you can review this later next week. We'll send you some additional information how to access this recording on next Wednesday. So stay tuned. Thank you again, Dr. Havryliuk. Thank you everyone for joining us, and have a great day or night, whatever you are, or morning.
Thank you guys. Happy scanning. I'm looking forward to connecting with you.
Wonderful. Bye. Thank you. And if you can complete the question in the poll, again, thank you so much for giving us your feedback. This will help us to plan future webinars and also understand what topics do you like, and please fill out that quiz before you leave. Thank you. We'll be closing this room in about 2 minutes for whoever's watching still in this room. So this webinar has ended. Thank you so much.